Good morning. Welcome to EPG Pathshala. I am Professor Tandon from the Department, retired professor from the Department of Community Medicine, Institute of Medical Sciences, BHU. And I will be taking you through the National Guinea Worm and the Yaws Eradication Program under the umbrella of National Health Programs and Policy. The development team has been headed, of course, by Dr. Vidya-mitra and his advanced team of specialists from all over the country. But before introducing the topic on eradication of Yaws and eradication of Guinea worm, we need to consider certain definitions. For example, what is control? What is elimination of disease? What is elimination of infection, eradication, extinction? Control merely means that the reduction of the disease has come to such a level which is a locally acceptable level. So that means we are bringing down the incidence rate, meaning the appearance of new cases in a defined period of time, in a defined area. Also, the prevalence. Prevalence means as the new cases collect together, the prevalence means at one point of time, the total number of cases which are prevalent in the community, morbidity, the illness which they create therein, and the mortality, if any deaths have occurred, but all this should come to a locally acceptable level. Elimination of a disease or an infection means reduction to zero of the incidence of a specified disease in a geographical area, or reduction to the zero of the incidence of infection caused by a specific agent. So whether it is the disease or the agent, we should bring it to zero so that we may say that elimination of the disease from a particular area has been done. Eradication. Eradication means the permanent reduction to zero of the worldwide incidence of infection caused by any specific agent. And extinction finally means that the causative agent and its disease presentations have totally disappeared from the earth, and the agent or the disease no longer exists in nature or in the laboratory. Now, following the eradication of the smallpox, several diseases have been considered as candidates for eradication. For example, the Guinea worm and Yaws are amongst the most predominant. We are today going to discuss the Guinea worm disease, which is also known as the dracunculiasis. The causative agent is the Dracunculus medinensis, and this disease, in fact, dances between the man and the cyclops. It is important to mention here that this disease, because of its strange habit, its strange presentation, occurs in certain defined parts of the country, wherein the people are dependent on, we have to walk for long distances and are dependent on water bodies in which they have to get down, walk in fact into the water, for example, spawn lakes and ponds, or the stepwells in Rajasthan and Gujarat area. And in this, the disease is transferred, creates a cycle between the man and the cyclops in the water and the larvae inside the cyclops. Man harbors the larvae, and the larvae, in fact, is ingested by the cyclops. They develop into the infected stage, and they come to fetch the water, and they carry away this infected water for their drinking purposes. The larvae, once that water is drunk, it is liberated in the stomach. It crosses the duodenum, and it enters the retroperitoneal connective tissues where they grow and mature. In fact, the males die after the mating, and the females migrate to parts which come in contact with the water. From the day of infection to the exit of the worm, this entire cycle nearly takes up 1 year. Now I show you a beautiful picture of a Guinea worm exiting from the peripheral part, that is the leg. I would like to mention here a certain important point, that once the patient starts to starts to show symptoms of the exiting Guinea worm, one has to take a lot of precautions. And if these precautions are not taken, there may be toxic reactions either locally or over the whole body. Where once the guinea worm starts to produce, it is necessary, it has been advised, that it should be permitted to exit very softly by itself, but and due care should be taken maybe to wrap it round with on a matchstick and cover the entire area with some tissue, with some say soft cloth, so that it doesn't hurt, and it should be permitted to come out by itself, because if any part is left behind, it may cause toxic reactions both locally and through the entire body. Now, in the global scenario, we'd like to definitely know something about what was happening before we entered into this eradication program, particularly with regard to our country. See, during the mid 80s, yes, before we go, 1980s to 1990 was known as the decade of the drinking water. And during this decade, it was estimated, because since this was so closely connected with drinking water, it was estimated that there were nearly 3.5 million cases in 20 countries worldwide, 16 of which were in Africa. And the same small picture, how on a smaller scale, was present in our country, especially in the areas of Rajasthan, Gujarat, Andhra Pradesh, Tamil Nadu, Maharashtra, and Madhya Pradesh. By the end of 1990s, of course, these cases started to come down, and because emphasis now was being given on good drinking water, and by the end of 2015, the annual incidence of the disease had decreased more than 99. We'll see a slide later where there were about nearly 39,000 cases in 1980, and by the end of the 10-year, there was a 99% decrease in these cases. Currently, the transmission has been reported only in the 4 endemic countries, that is Chad, Ethiopia, Mali, and South Sudan. Majority of the people have been based in South Sudan. Now, country certification. What does this mean? This means that for a country to be declared free of dracunculiasis, a country needs to have reported zero transmission and afterwards maintain an active surveillance for at least 3 years. That means no case should be reported for 3 years before we can say that the disease has been eradicated from that particular country or state. Till date, WHO has certified 198 countries, territories, and areas belonging to 186 member states. And India completed its guinea worm disease period free from July 99 and was declared as guinea worm disease free in the February of 2000. In this venture of eradication program, the Ministry of Health and Family Welfare was actually launched the National Guinea Worm Eradication Program in 83-84. And this was a sharing basis, 50-50 sharing basis between the center and the states. And the object was eradication of the guinea worm disease from the country. The National Center for Disease Control, formerly known as NICD, Delhi was designated as the nodal agent. The program was implemented by endemic state health directorates through the primary health care system. Now, why was the primary health care system needed? Because since this problem was seen at the grassroots level, at the rural areas, in distant places where people had to walk for long distances, and lots of people were dependent on these single water sources where they had to walk into the water to fetch the water. So therefore, the primary healthcare system was an important addition to the lifeline care of seeing these cases. Now, like I said previously, 39,792 cases were seen in 84 in all these places, maximum of which were in Rajasthan and Madhya Pradesh. Now, both these areas are those places which have a water scarcity. Either these are not well developed, there are jungles, there are deserts, so such people have difficulty in getting water at their doorstep. The last case of Guinea worm in India was reported on 6th July 1996, where Mr. Ram, 25 years, from a village in distant Jodhpur, had reported Guinea worm eradication. In fact, his father had had Guinea worm, and his brother and sister also had Guinea worm. So these were the last cases. But since the government started the case detection and the continuous surveillance program through three active search cases operations, and these three active search cases per year were done in the months of April, June, and December, and regular monthly reporting was done. Now, most important was the case management. See, once you detect the cases and you keep a continuous surveillance on where the cases were occurring, now we come to the case management, and the vector control comes second. The case management, if these cases were found with reporting the exit of a Guinea worm, immediate steps were taken to help educate the patient as to how to manage the Guinea worm exiting. Plus, he was given medicines to control the infection. And vector control was done in the water, where 10-phos 50% emulsion solution was put in these unsafe water sources at least 8 times a year. And most important, all these people were taught, or were in fact health educated, to the using of fine nylon meshes or maybe double-layered cloth strainers by the community to filter the cyclones in all the drinking water which they were getting. And the most important, provision and maintenance of safe drinking water supply came on a priority basis. Now, this meant that the staff from the primary health center or from the CHCs had to send trained manpower into the field in order to do a complete IEC, that is information, education, and communication for these areas, priority areas, which were hit by Guinea worm. And intensive health education was, of course, very important, in which they went on to teach the actual shifting between the water and the patient. And from the active side, that is concurrent evaluation and operational research, were continued by the district and by the state authorities to check on the recent status of the cases at that time. Case detection. As I've said, April, May, June, active case operations were conducted, and they were shown case recognition cards every year by the paramedical person of the concerned PHCs. Now, the quality, a quality was maintained for the search operations so that not a single case could be missed, since this was actually aimed at eradicating the entire disease within a certain period. Cases are also detected through self-reporting. With so much of health education in the community, people started reporting themselves and presenting themselves for treatment and for care. Village markets were used as a very good area for a weekly survey, as well as for a complete strategic IEC program in order to educate the community. These were some of the important. Of course, case management the aim was to encourage reporting and stop contamination of water sources. Vector control was very important, since emulsion had to be put in, the 10-phos, and they had to be done till they could find that, and along with the use of fine nylon meshes, so that a complete reduction in the very source of transmission of cyclones from the water, from the infected body of water into the patient was completely zero. And most important, provision and maintenance of safe drinking water was to be done, especially for the affected villages. Health education and community involvement are absolutely essential markers as far as any community program goes, because without the communication between a community and between the medical personnel working in the community and the field workers, no program can prove to be a success. Of course, the program was implemented to the primary healthcare system, and the chief medical officer and the health officer at the district, the medical officer at the primary health center were totally responsible for planning, implementation, monitoring, and supervision. Now, the national control, the NCDC, is the nodal agency for overall planning, and there was a continuous movement of information and knowledge between the lower level and the higher levels, so that at any one point of time we could actually know what is the status of the guinea worm incidents in the states or in the particular area. National Drinking Water Mission under the Ministry of Rural Health Development coordinates all the provision of safe and maintenance of safe drinking water supplies through the State Public Health Engineering Department. The following activities, as continuing as per recommendations of the International Commission for Certification of Dracunculus eradication, was done through Geneva. Health education with special emphasis on school children and women in the rural areas, because women form an important component between the water, the house, and between the family. Most important, now because education had been given in good quantities, and therefore a rumor registration was started, and followed by a rumor investigation. This was important. If somebody said there's a case in a particular area, immediate investigation was done. Maintenance of guinea worm disease on the list of notifiable diseases and continuation of surveillance while in the endemic. Before beginning on the eradication program concerning Yaws, I would like to just mention another factor that is pertaining to guinea worm. Guinea worm, this is also known as endemic trypanomatosis, and most commonly it is known as Yaws, also known as Frambosia or Piang, caused by Treponema pallidum, the subspecial that is pertinue. Other infections belonging to the Treponema group is also endemic syphilis, also known as Bigel, but this is caused by Treponema pallidum, and its subspecial is endemicum. And the third one is Pinta, which is caused by Treponema caritia. Now, occurrence. Where does this occur? Since this is a disease which concerns mostly the skin, it has been seen that to occur in poor communities in the warm and humid tropical regions of Africa, Asia, Latin America, and Western Pacific. Almost 75% of the people affected are children below 15 years, although the peak incidence occurs between 6 to 10 years. Overcrowding, poor personal hygiene, and poor sanitation facilitate the spread of the disease. Most important, which we would like to say, is that now when we talk about the areas of the hot and humid, we come to the areas pertaining to our country. And these areas with the same climatic subtropical changes were seen in the northeast, in Madhya Pradesh, in Andhra Pradesh, wherein the jungles and the hot and the humid climate helped, in fact, in the spread of Yaws. Yaws is actually transmitted directly from person to person. So, therefore, a close contact is needed. This close contact between families, between children, is always found in the poor communities living in small huts, living in close contact with each other. Now, when the person gets Yaws, he presents with a skin infection which starts exudating, and actually the spread of the disease occurs with the help of these exudates and the serum from the infectious lesions. Now, most latent and incubating cases are found in clusters around an infectious case. Obviously, if there are a large number of children in the family, they're all going to sleep together, and this infection and with the bad personal hygiene conditions and the bad environmental conditions, this disease easily transmits itself around different children of the same group in the same company. And so, in fact, if you want to trace, this can be done by cluster testing. You find one case, you can find the other cases by knowing who his friends are or who his family is. Now, what are the clinical features? It actually presents as a primary skin lesion and it's known as early yaws, which may persist for 3 to 6 months. But these skin lesions, although they have the exudates and the serum which comes out and they infect other persons, they heal spontaneously. Often it leaves a scar. Unfortunately for us, this has a very bad effect on the internal bone system, which actually where the pains start. These are the nocturnal pains and the tenderness of the long bones, especially the tibia. And often these are accompanied by inflammation and periostitis, which is very common. Since these people are lacking in medical help, these pains continue till such a time within 5 years we can actually see destructive lesions of the skin and bone wherein deformed features can make themselves present and the deformed cartilage, broken cartilage may appear, which obviously are non-infectious but may make a person very disabled and very unhealthy. In India, the disease is mostly known by different names depending on the places where it is found. It's known as Madhya Roga or the Gondi Roga, Koya Rogam. Some of these names of yours are based on its clinical features and mostly found in the northeast. Is spreading to Madhya Pradesh, Andhra Pradesh, and Maharashtra. Approximately 9 million of the 62 million tribal population in the country were at the risk of yaws. Now, as I've already said, these cases present with small lesions on the forearm or on the legs, which present with exudates, and which, if not taken care of, we will easily transmit the infection from one child to another. In the global scenario, in the period 1950 to 64, in fact, WHO, in close collaboration with UNICEF, launched the Global Endemic Drepanocytosis Control Program. More than 50 million patients were treated in 46 countries, reducing the overall prevalence of these diseases by more than 95%. So the control strategies actually changed frequently, and it was changed from a vertical program to merge with the horizontal program. And that is why this was initiated, of course, to the CHCs and to the PHCs, mostly in the endemic districts, and which definitely led to a dramatic decline in yaws transmission, since these programs were actually actively accompanied with good health education programs. Subsequently, active anti-yaws activities were abandoned in the majority of the states, and the program, as I said, was made horizontal through the network of primary health centers and sub-centers. Now, yaws eradication in India. This was launched way back in 96 and 97 because soon this was actually running in a way parallel to the Guinea worm eradication program. And after seeing the success of that previous program, definitely we were heartened to know that yaws could be eradicated from our country also. This was launched as a pilot project in the Koraput district of Odisha, and it eventually extended to 51 endemic districts in 10 states, that is Andhra Pradesh, Odisha, Maharashtra, Madhya Pradesh, Chhattisgarh, Tamil Nadu, Uttar Pradesh, Jharkhand, Assam, and Gujarat. Now, all these areas, if you see, are subject to very warm temperatures and crowded conditions, and mostly then 1996 to 2004, number of the reported cases started coming down once it was merged with the horizontal program. IEC program started, case-to-case detections were started, and case reporting was encouraged. So these cases started coming down from 3,000 cases to actually nil during this particular period. Then 19 September 2006, it was finally declared as eliminated since the cases absolutely touched zero. Now, for certification of eradication, when no indigenous case has appeared in the population for a period of 3 years, based, of course, on very active searches and routine surveillance, then only we can give the certification that the disease has absolutely gone from the area or from the community or from the state. And most important, since we are talking of infection, maximum infection, which was seen in 6 to 10 years of age, serology was to be done between 0 to 5 years. And if this could be touched as two levels of 0, then we knew that our program was well on the way out with the success to become 0. Now, objectives of the program were launched. This program is in fact launched to see the cessation of the transmission of Yaws in the country. That means no infectious cases were seen and no seroreactivity in under 5 children. The main strategy, of course, was based on surveillance and containment, manpower development, case finding, treatment of cases, and of course, the contacts and containment of the infection as far as possible. And most important, the IEC activities harnessing all the people from the multi-sectoral areas. Case finding active. Once a case was reported or was found, then immediate active case finding was done by house-to-house visits by the paramedical workers for searching for cases of Yaws. During these searches, at least 90% of the population was surveyed, and in tough terrains where frequent visits were not possible, total mass treatment was carried out, which was a big advantage in this program since treatment was available and could be given and need not be given again and again. So contact, communication, case detection, management were also done at weekly markets in the tribal areas. Routine surveillance was strengthened by the training of the paramedical workers, and they also identified the period between the active searches. Now, laypersons were also the village, and the laypersons are also taken into this program, wherein people were shown colored photographs of these Yaws cases so that they could recognize and report any cases which had not yet come into the picture of into the framework of the workers themselves. And of course, the workers from the other departments were also pulled in. For example, the tribal, the forest, the education department, all of the surrounding areas were pulled in to help. And most important, we shouldn't forget when we are doing this, the rumor investigation and the rumor reporting, definitely very active. Now, this is a card you can see patient and mostly the children, of course, and they were shown and they were asked to recognize that if they could see any children with these type of problems, they should report immediately. Now, treatment is a very, very positive aspect as far as Yaws eradication is concerned, because the recommended treatment is actually benzathine penicillin in a single injection, which is very advantageous. For over 10 years, you give 12 lakhs. For under 10 years, you give 6 lakhs unit once. And for those allergic to penicillin, were given erythromycin and tetracycline in the doses of 500 milligrams 4 times a day for 15 days. Along with this, health education to keep themselves comfortable, clean, and treated. Infrastructure, of course, the state directorate, since this was becoming it was merged with the horizontal program, the state directorate had a main say, as well as the Department of Tribal Welfare, and all the health manpower in the endemic districts were trained this program and helped to bring out the cases into the open, wherein they could be treated and eliminated from the active group. Now, ongoing activities as far as now, one thing is important is that as per international requirements to eradicate any disease, the monthly surveillance, the active search the operations, verification of rumors, health education, most important, the sero survey in the 1 to 5 years is absolutely essential. And they must continue till we see that it reaches the required stage of 0. So, to summarize, the National Guinea Worm Eradication Program was launched in 83-84. Subsequently, the last case was reported in 96. 3 years later, it was tagged as a guinea worm-free, disease-free period to 1999. Subsequently, the country was declared guinea worm disease-free by February 2000. Most important, care was taken to health educate the villagers, especially those with the blisters and their surrounding, drinking water, filtering the water through, and as well as trying to make arrangements for alternative safe sources of water. In as far as Yaws goes, Yaws we know that it affected the children mostly living in close. So education, information, education, communication was one of the most important mainstays in this program. Catching the diseases early, treating them, and seeing that the disease was down to 0 level, and it was finally declared eliminated in 2006. The prevention and control measures of Yaws infection included case finding through active and passive surveillance, reporting by lay persons on seeing Yaws, recognition card, in the presence of cases and contacts, and through the mainstay of IEC activity, harnessing the total approach. So, with this, I thank you for visiting this EPT Pathshala on the National Guinea Worm and the Yaws Eradication programs. Thank you.